So last week, the MahamaCares program was passed into law. We're not sure yet if the president has assented to that bill, and we'll clarify that tonight. But it makes big changes to the way we take care of those who can't afford when it comes to chronic diseases. And by the way, it's not only about those who can't afford, it's for everybody else who's suffering from a chronic disease. The state says they are going to intervene and provide a very structured, sustainable care for everybody. So far as you are Ghanaian, so far as you've been diagnosed with a chronic disease, the state, and you apply, you qualify, the state will take care of you. And there are structures that the state is proposing to set up and has set up under this law. And we need to unpack this because it has fundamental implications for the way we had administered our healthcare over the many years. And we know that this was passed under a certificate of urgency in Parliament. It tells you how important it is for the government of the day. And that's the first thing you notice. But a few things that we also notice as far as the various chronic diseases are concerned that is written into law. If you have diabetes, for example, if you have cancer, if you have kidney failure, heart disease, and even stroke, the state says they'll take care of you. They'll take care of you under this particular arrangement. And this is actually not just taking care of these diseases. It's also about infrastructure and everything else that they need to be set up. Training even is there also to take care of these. Can you imagine diabetes now becoming one that the state will take care of fully for you? And we need to ask those questions about, is this even sustainable? How long are you going to take care of the diabetes for this individual until they pass on? Those questions we'll ask tonight to get clarity and understanding of what exactly the state is planning to do under this particular law. But also we know that 36.7% of all the deaths that we currently have, and this is according to the Births and Deaths Registry, they gave us this data, is down to chronic diseases. So this is a big problem for us as a country. And many households are struggling as a result of the burden that this imposes on people. And you look at pneumonia, look at hypertension, heart failure, respiratory, stroke, diabetes, some of the ones that I mentioned earlier that this will take care of. And the NCDs, or non-communicable disease control program, that unit is what really existing structure to deal with this under the Ghana Health Service, right? So what is the objectives of this medical trust fund? That is the official name in the law. But of course, in the law, I also see, at least in the preamble, it also says, also called the MahamaCares. And so let's call it that because it's in the preamble of the act. But what is its objective? And as I said earlier, primarily provide financial relief for patients who are struggling with these chronic diseases, but also expand access to specialist care. And that for me is a fascinating one. So how exactly is this particular law proposing to expand access? We'll hear about that and learn a bit more on this. But also establish what they call the National NCD Registry. What is this? My guest will tell us. And then support the research and training. So this is very broad. And the minority have been responding. I'll tell you what they've been saying on the back of the passage of this under certificate of urgency pretty quickly. So how do you qualify if you're home? How do you even begin to think about getting the state to support you in one of these diseases? Is your lot, unfortunately. One, you must be a Ghanaian. Two, you must be enrolled under the National Health Insurance Scheme. And so note that if you're not under the National Health Insurance Scheme, you will not be covered. And that is why some say, so why don't you simply expand the National Health Insurance Scheme? Why must you create a whole bureaucracy for this when you already have a National Health Insurance Scheme? And so expand the list of diseases that the National Health Insurance Scheme takes care of and include these under that. The previous government started something like that, where they were taking monies from the NHIS and taking care of those with kidney disease, for example, with a plan to expand. So the critics say, why create a bureaucracy? Why create another administrator, a fund with board members, etc., and obviously add costs to the state when you can simply use established structures under the National Health Insurance Scheme to take care of that? We'll get clarity on that very fundamental question for you. But that's the second qualification if you indeed want to apply for that. But also you must be diagnosed now with a chronic disease, right, to qualify. So question of funding always comes up. According to the Act, and it's written in the Act, they anticipate that they're going to be spending $3 billion annually on this alone. But I also find something fascinating. In addition to $3 billion, they also say they're going to spend $59.7 million over a 3 years period in infrastructure. I mean, and that was separated. We treated line item in the law was a separate item there. I wonder why. Because if you really look at it, $59.7 million is a tiny drop. What really can it do when it comes to infrastructure? And a list of things that it says it will do. But broadly, they want to spend $3 billion annually on this. Key question is, where are you getting the funds to come up with $3 billion annually? And can this economy contain that? And here is the answers they have in the law for this. 20% is going to come from the National Health Insurance Fund, right? So the fund is already there. So if you're going to take 20% off this to take care of the MahamaCares program, again, back to the question, keep the 20% where it is currently and then expand the NHIS. We'll ask that question. They also plan to get money from budgetary support. So this is government allocating funds to it. And then investment income. So part of the money that will go into this fund, the trust fund, will be invested by, they will appoint, an organization to, of course, administer the funds on their behalf, and they will invest that. And the investment will bring income, and they expect that they can then use that income to take care of you if you fall within that particular bracket. And then they're also looking at voluntary contributions, and that is why you've seen that this government, the president gave the instructions that its appointees would sort of devote, sacrifice part of their salaries that will be put into the MahamaCares program, and private sector is also encouraged to bring in money into the fund. So these are the four main areas where the fund plans to get funding. So if you look at the actual numbers, right, going back to what we know from the 2025 budget, the 2025 National Health Insurance Levy revenue, for example, is projected at $8.57 billion. If you look at the 20% of that, we're talking about $1.7 billion. So that is what is going to come in as far as the 20% from the National Health Insurance Scheme Fund is concerned. And so then you ask the question, there's something else that must come from somewhere else. It must come from government, must provide the remainder of the $1.3 billion. The investment income must also come in here to show up and make up for this. And then you're also expecting, according to the law itself, that the private and voluntary donations will all come up to this $1.7 billion annually. And so this is a stretch. You're hoping that a lot of things would work. The investment will yield the returns, that it will give you enough money. And then people, out of the abundance of a good heart, will donate to it. And then the government, obviously, right? Because government is obligated, because they set it up to put in money. Are we going to find a situation where government will be finding this a bit too burdensome? And then the coffers get dry, and then we run into the NHIS problem that we have currently, where claims delay because government doesn't pay, or for whatever reason. Because this one is not direct a tax item imposed on us to put money into it. Because indirectly there is there, because the 20% we pay the NHIS levy, 20% of that is coming into this. But so there are a lot of questions there that we need to ask when my guests sit down. So how does it really work? You can apply. Your specialist who is taking care of you can apply on your behalf, and then that application goes to the fund. They will review, a decision will be taken, and then the patient will receive the package that indeed has been specified, and the cost will be taken care of completely for you, right? But there are some challenges. The NHIS capping, which this government had dealt with, I believe that's no longer a problem, but they have delayed government funding, which I mentioned earlier, which has plagued the National Health Insurance Scheme. How do you avoid that? Low NHIS premiums. Is it now a good time to talk about increasing the premiums? On the back of this, we'll talk about that hyper compensation cost. But I see in the law that they prohibit the fund from overspending. You have to spend exactly what you earn. They can't spend more than they have brought in. And then they can also spend, administrative costs cannot be above what they actually spend on their core responsibilities there. So this is the minority's point on this. The minorities say, simply retain the COVID-19 levy because you get a bit more money from there. The NHIS risk being weakened, because if we're taking 20% from there to do just MahamaCares, that leaves a hole in there called opportunity cost. They're making the point, they expand NHIS coverage. the argument that I made earlier, which they've also made. And the 14-day approval window, they believe, for processing it says poses risk. Okay, let's have that conversation tonight, because a few things must happen now for this to become reality. They must establish a headquarters, and that is where the administrative cost comes in, the bureaucratic cost, right? Because you have to look for and house them. And then you have to appoint that administrator, and then you will hire staff. So this will all bring in additional costs. So must we do this? Is it even necessary? Don't we have structures in place to already deal with this problem of chronic diseases? And will this really solve the problem? And it's been passed already. Question is, has it been assented to by the president? And is a law now? My guest will weigh in after this. This has to do with all of us. And so I'm looking forward to this conversation. Stay with me. And thanks for staying with us here on PM Express. It's always brought to you by Syntex Tanks. It is strong, it is tough. Also brought to you by Pepsodent Cavity Fighter and the Academic Times newspaper. My guest joining me for a conversation tonight on that big legislative instrument that was passed in Parliament. You call it the MahamaCares, but it has a more technical name than that. The trust fund that has been passed now. Professor Titus Bayo is a board chairman of the Kolebu Teaching Hospital. And Titus, you are on one of the committees in Parliament, I believe, Health? Good. Good, fantastic. Thank you very much. So that's Prof there joining us. Alexander Kwesiakwa is a former Deputy Minister for Health. Grateful, Alexander, that you're joining us. Also because your term, you also did something around this chronic diseases. I'm curious to know your thoughts on this. And Dr. Kwame Sapansiudu had written quite extensively about this. In fact, we discussed this, Kwame, last year when we were doing our manifesto analysis, because this is something that the NDC had said in their manifesto. So now that they've implemented it, now we know exactly the form it's taking. I'm curious to hear your thoughts on this. But Prof, let me start with you, Titus, because I'm not sure if this has been assented to by the president. Do you have any clarity on that?
I was just doing some checks, but I do not have confirmation of that. Yeah, okay. But I hope that it will be soon.
You guys passed it last week, I believe.
Yes, I think it was last week.
Yeah, last week.
Last week.
And it's a of agency.
Yes.
Okay. You agreed it deserved that treatment?
Oh, yes.
Why?
Evans, good evening to your viewers and good evening to my colleague. I mean, we are talking about lives here. If providing health care for people who need dialysis, who need some cancer care, who are in some critical stage is not urgent, I don't know what else is urgent. No life can wait. So we debated it on the floor, and the House agreed that it was urgent, and so we needed to pass it that way because there is no time. I mean, it was the former president who said they can revive the economy, but they cannot bring back lives. And so I don't know how, there's no better way to emphasize the urgency of this. I mean, for those people suffering today, they wish this had been passed yesterday and the secretariat set up. For someone who is on the social media appealing for funds today, for a constituent who is looking for money today, they wish this had been passed a month ago. So there's no time to waste.
And Alex, you don't disagree?
No, I think that on our front, we have a different position. We think that we needed some time to go through it and make sure we come out with the best. Apparently because NHIS is there, is not covering all the disease burdens though, but if we had money to invest into NHIS by the formula that NHIS operates on, 95% of disease burdens in Ghana could be taken care of by NHI. And so if we have had a cap of NHI by 15%, and government decided to take the cap off and decides now to take 20% out of it to set up a different entity. I mean, between when that entity was set up and now and the days ahead, people who are suffering from those chronic diseases are still going to continue suffering, or to find some other means of taking care of those conditions.
Okay, that's an important point. I'll come to Kwame to set us off with his own assessment quickly. But on that point, because we're talking about the urgency of this, what is the interim measure for those who currently haven't, say, kidney? Because they started some support using the NHI extra funding last year. Is that still in play?
I can confirm to you that it is.
Okay.
As of today, people are having dialysis on NHIS in Kolebu, and I can confirm that across the country. But you know, the urgency of this, Evans, and I want to emphasize it again, that, you know, setting up a scheme like this, you need some processes to go through. We need first the legal basis to be, even for them to have the authority to even operate an account. Without that, people have already started donating money, but you can't receive and put them into any fund because there's no law backing that. You need a secretariat to help manage this. You need certain regulations. You need forms through which people can access this. So all these intermediary processes will take time. And for every additional day delayed, there is a life potentially that could have been saved. Or some malignancy that could have gotten worse that could be arrested. And so I do not see what reason we could give to delay this further. Okay. He knows that Parliament is rising on Friday. So we wait for this very long break of Parliament and come back in 3 months' time. So even if the processes takes us a month to complete everything, assented, and it starts to work, if you delayed it for 3 months, that is 3 months plus an additional month. And for those patients, they simply cannot wait. And the issue of just expanding the NHIS is not a solution to this.
We'll come to that.
We'll come to the merits.
Because that is a very substantive matter to debate. But let me bring in Kwame. Kwame, so what is your assessment of the bill as passed? We're waiting to get confirmation whether or not he has been assented to. It is now formally law. But as it is and as was passed, give me your assessment.
Thanks, Evans. It's not just my assessment. If you recollect, Multimedia held a national dialogue when the dialysis crisis happened. And there were certain things that came out of that dialogue. One of which was that it was accepted by all the stakeholders on the dialogue, including the then government, that we needed a dedicated fund for the management of chronic diseases. Because I clearly remember that I set the dialogue off. And one of my pet peeves when I set it off was that we're talking about dialysis, but there were other end-stage chronic diseases that needed to be looked at, like cancer chemotherapy and all that. And the clips are there so people can go and listen to it. So the first thing was that we needed a dedicated funding. That was ring-fenced, number 2. That was sustainable, number 3. And that would be managed independent of the long hands of government, number 4. And this is not me saying it. This was the outcome of the Joy dialogue, if your memory serves me right.
Yeah.
Events. So when we assessed the manifesto, if you remember, and that's why I've drawn you back to June of last year, because then 31st of October, I was in Ghana and we assessed the manifesto. I assessed the manifestos based on what the dialogue expected. And I remember that day while walking out of the studio, Titus is my friend. I met Titus downstairs with Dr. Siasari, and I was laughing at them, and I said, You people have put proposals out, but you didn't test the proposals against what the dialogue said. And so for me, when the bill was passed by Parliament, the first thing I did was to marry the bill against the outcomes of the stakeholder dialogue that multimedia held. Because you had the patients on, you had government on, you had the health professionals on, and you had advocacy groups like myself on. And so when you look at the bill as passed, it satisfies all the requirements that the stakeholder consultation was looking for. Why do I say that? We wanted a ring-fenced funding. Now the government has said 20% of NHIS, so we exactly know where the money is coming from. And when you talk about ring-fence, it means it has to go to an entity that technically is out of the reach of government. So a trust fund has been set. That's another thing that dialogue asked for. So that has been done. Number 3, it had to be managed on behalf of the patients. So a board has been set up. That has been done. And number 4, there had to be sustainability. There is an index to say 20% of NHIS, even though I have a problem with the funding model, and we'll come to that, but I'm just going by what the dialogue agreed. Sustainability, so you know that whatever it is, when the NHIS funding is agreed and approved by Parliament, 20% of that goes to management of chronic diseases. The point I would do, and it's a slight correction, if you look at what Parliament approved for NHIS this year, it's 10.7 billion.
Okay.
So that slide that you presented at the outset is because, so if you do the calculations, 2.14 billion that comes to the funding. Because 10.7 billion has been approved by Parliament. Like I said, I have issues with the funding and we'll discuss that. But it's 2.4 billion. As to whether that would be enough or adequate or below par is another question that we can discuss. But at least, if I want to hold the standard bearers to account, I am clear in my mind because I was part of the resource people who helped Parliament go through the budget at the end of its reading. I know the numbers in the budget in the appendices, and I know I am talking about 2.14 billion, and I can go straight and say, Prof. Bayo, you guys on the Health Select Committee, this is what you approved. This was going to the National Trust Fund. Help me understand how you account for that. And for me, working in civil society, that is gratifying. Because if you remember, Evans, after the dialogue was held and the government then tried to solve the problem with just dialysis, they voted an amount of money, which I then at that point spoke to you again on PM Express, and I said, it's not enough, but we cannot let perfect be the enemy of good. So I would rather we run with that money, save lives, than say we're going to hold an argument that as to what is adequate and see people pass away because they couldn't afford dialysis. I am applying that same approach today and say I have issues with aspects of the funding model. That is, and let me be clear, that is the only part I have issues with. The bill as it stands, I support 100% because it answers all the questions that were posed at the dialogue and technically the communique that was issued. But I have problems with the funding.
Okay.
But because I don't want perfect to be opposing good. I would rather we run with this while we have the funding argument than to say what the MPP is saying, let's hold on, let's get it perfect before we roll it out.
Okay, and Kwan, before I come to the studio, the MPP's fundamental question to this is if you're taking 20% from the NHIS and allocating it for this purpose, so why don't you just expand the NHIS and use it as a vehicle to take care of this anyway? And they've started something, you can call it a pilot with the kidney that you can extend.
You see, that is an argument of substance and form. Different countries have used different vehicles. I'll use the country in which I live, the UK. It is run by the NHS, a similar scheme for end-stage diseases and all that. But they have another entity known as NICE, National Institute of Care Excellence, which then negotiates what can be funded and what cannot be funded. So even though the NHS is helped or expanded to take care of these things, they cannot act independently unless NICE approves what they can pay for. If you read this bill in a stricter sense, Ghana has decided to combine NICE and that aspect of end-stage disease management into one body. Because you read a bill and they are supposed to make the determination of what can be funded and what cannot be funded, equipment, all which is done by NICE in the UK. That's how the Scandinavians do it. So I am not prepared to have the argument of which vehicle we use. I am prepared to wait for the vehicle to run and for me to examine its efficiency, because we are dealing with human lives here. And the other thing I would say to answer your question, Evans, is this. If you look at it, we are talking about chronic disease, but for someone like me in advocacy who's read the bill to the letter, the bill is not about chronic diseases. It's about anything. It takes off when the NHIS stops. So let's say hypertension. If you went to a hospital today and were diagnosed with hypertension and were prescribed a beta blocker, a calcium channel blocker, the NHIS will pay for it. The trust fund would only kick in if, as a result, you had renal failure and you needed dialysis, which is not paid for by the NHS. So when I see the NPP's argument, I see it as marrying the concepts. You have to read the bills in tandem with what already exists, which is what I have done. Because I was at the outset part of the dialogue that was organized by Multimedia, so I have always read this to see, does it answer the question and does it address the outcomes of the communique that was reached after the stakeholder dialogue? So the vehicle, we can always argue, but different countries have used different vehicles. Like I've said, the UK used a vehicle where they enable the NHS, but have NICE to regulate them to say you cannot pay for this because it's too expensive and it doesn't add what we call quality adjusted life years because the cost benefits are not there. Or you can do it the Scandinavian way where they combine the two and it's an independent body. The point is, what do we want? Do we want life saved or we want the best vehicle? Because the answer is, so far, no vehicle has been shown to be the best. The NHS cannot argue that it is better than the Swedish model or the Danish model or the United States model where they use the PMBs. So for me, I'm not prepared to have the vehicle argument. Rather, I am prepared to have the argument about the efficiency of whatever vehicle has been chosen.
And now we know the nature of this vehicle. Stay with me. Alex, how do you respond to Kwame?
I don't think we had issues with the vehicle. The problem we had as a country was the funding. I mean, NHIS had been established. Year on, we have added on to it. Initially, it was supposed to take care of 95% of all disease burdens. Remember the free maternal care?
Yeah.
It was from a grant. And when the...
From the UK.
For the UK. When the term was finished, NHIS absorbed it. So gradually, we've added on. And so the vehicle has never been a problem. The problem has been the funding. And so NHIS will tell you, I cannot pay this because I don't have that much to be able to expand my coverage. And so if government, you see, the Association of Private Healthcare Providers.
But it's interesting you make the point because going by the correction that Kwame makes, the 20% of the 10 billion, it's what, 2 billion?
2.1.
Right?
Yes.
10.7.
And the law says we want to now spend 3 billion annually.
Yes.
So that is...
So the gap is coming from the ministers who have been sanctioned.
Because I'm making this point because you said it's not about the vehicle. But it looks like the NHIS is so largely funding this arrangement anyway, this new one.
Yes.
So the NHIS is going to do it anyway.
Certainly. So I'm saying that if we had maintained the NHIS and the kind of funding that we're taking out to set up a new vehicle, we have problems with it. So if government decaps NHIS and is able to free NHIS with an additional funding, then NHIS can now decide to open up like it's done in the past.
So in other words, you keep NHIS as it is, you give it more funding.
That's it.
They expand the list of diseases that they cover to include chronic.
That's it.
And you simply
and it settles. It settles because at the end of the day, you are going to spend money in maintaining that new vehicle you are creating. You're going to spend money to maintain that new vehicle you have created. You've seen the structure.
In other words, keep the 20% still with NHIS.
That's it.
And then add on a little bit. Because if you need 3 billion and 2 billion is coming from NHIS anyway, then you need 1 billion.
And
right to the NHIS to take care of it.
I have said,
okay.
I think that I saw that in your intro. Is it not about time we start talking about the NHIS premium? Nobody has that political will. But now that we have the political will to expand and include chronic diseases that people are spending so much on, if we start talking about increasing the premium of NHIS, will that not help us solve the issues?
I mean, Prof, let's stay there because we're trying to still understand. It's about whether this works, right?
Yeah.
And Kwame says, will this vehicle run efficiently?
Yeah.
For it to run efficiently, you have to consider whether the amount of money you're giving it, is it the most efficient way to use the 20%?
Yes.
Question is, if we take the 20% from the NHIS, that is opportunity cost for NHIS.
Okay.
So 20% less to do other things,
Okay.
right?
Yes.
So how do you square that circle?
Okay. So let me...
Whereas, as per argument, if you keep the 20% there and then you add on, then the vehicle is intact, you've added on and you're expanding what they would normally take care of to include chronic.
So I think we need to understand the thinking that has gone into this novelty of idea of creation that we've brought. The fundamental thing is that Kwame mentioned the Scandinavian model, the UK model, there's the American model. We are creating a Ghanaian model of what we think will work for our country. The thinking is that we have non-communicable diseases burden increasing. There's no doubt about that. We're having challenges with the funding of it. Now, if you look at the NHIS model that we have, if we decided to add these chronic diseases, these chronic diseases are already on it, all right? It's just that at some point the NHIS stops. So you have hypertension, NHIS will manage. You have renal failure, you need transplant, NHIS cannot continue. You have cancer, early stages, diagnosis, screening, NHIS will manage. You get to radiotherapy, chemotherapy, hormone modulators, NHIS cannot continue. Now, the current model of NHIS, if you added these diseases without any modification, NHIS will collapse. And I'll tell you why. NHIS is based on diagnosis group related pricing system. You use a diagnosis and determine a price. Now, if you take a condition like a cancer, a typical cancer like cervical cancer, and you just bill cervical cancer, even the financing model is going to be chaotic. Now, you needed a special purpose vehicle, which marries what Kwame talks about, that there is a group that thinks about the ethics of it, who benefits, what support. This is not an all-size-fit-all model that we are talking about. We are talking at the terminal end of diseases. There are some people that if you offer them 100,000, the quality of life they would have would not be worth that 100,000. They may even pass on before you finish. There is somebody when if you give 50,000, that person will live to contribute to the GDP of this country and be much beneficial. If you use a wholesale approach like the NHIS model, once the diagnosis is made, everybody gets the same thing. That is not an efficient way to use money. So the concept was that, can we define a Ghanaian model that is sustainable? Now, this funding arrangement, you said we'll talk about, but let me just...
Let's go there.
Let's go there now.
There's a substance.
Let's just go there now.
I think it's very primary.
Yes.
I think it's fundamental to the success of this.
Excellent. Now, we think that this vehicle will be perfected over time. The reason why we thought that we could not wait, let us start with what we have and perfect it over time. We are creating an entirely new model. We are not copying a UK model. We are not copying a Scandinavian model. We are not copying an American model. This new model we are creating, we set up this trust. This trust is giving initial funding, and this funding will continue. It's a guaranteed source of funding from the NHS. And let me just quickly add that this money that we are talking about 15% of it already, was never accessible to the NHIS anyway.
Because it was capped.
Was capped, and the NHIS was functioning. That money was going to the consolidated fund that you and I cannot account for what it was being used for. Now we are purposing it for health at a terminal level to help give people hope.
5%.
And we are raising more money. Now, the funding model, we went for this model, but we have other anticipations of funding. But there are some technical challenges, which I explained to him before we came to studio. At the time of passing this bill, you cannot introduce any new tax handle, right, through an act like this. He knows, by the way our laws are made, only the finance minister can come through and introduce a tax handle. You cannot modify tax through a back door channel, through a bill from another ministry, right? Different wonderful ideas came to the discussing table. Can we take from the NHI, because NHI is primarily responsible for health, and manage it more efficiently for that end, and add other sources? For instance, we have what we call the assent tax, which came up strongly during the discussion of COVID. I was on that panel that Kwame talked about. I was there. I was part of the panelists. We are charging people who are taking sugary drinks, fizzy drinks.
I remember you made that.
I made that point.
That was your recommendation in the dialogue.
That can we ring-fence that tax or even increase it and save it? Because we are telling you, don't smoke. When you smoke, you get cancer. You decide to smoke. And then when you fall ill of that same cancer that we warned you against, the rest of the people have to contribute money to take care of you. We say, don't consume this. It will give you diabetes, it will lead to renal failure. You do it. And then my little taxes is all that is put together to take care of you. So why don't you charge you a little more for that behavior that increases your risk? And then when you fall ill in the terminal stage, that fund is...
But that's not part of the sources.
And I'm just telling you that, so the law itself opens and that other sources of funding, because we have to establish this law, and in subsequent years, subsequent budgeting cycles, we can look at other financing models like this. As it has been discussed extensively at the committee level.
So let's look at what the bill, as it is now, because you don't know if the president has sent it to it or not. As it is now, what it prescribes.
Yes.
The only source of fund that's guaranteed is your 20%.
Guaranteed, I agree.
20%.
I agree.
Your investment income, not really, depends on a lot of factors. So you really don't have too much control.
Agreed.
And then the donations.
Yes.
Also, you don't have control.
Yes.
But then the government allocation, because there are 4 sources I see there. There's a 20%, there's government budgetary allocation, then you also have the donations, and then you have the investment income. Those other 3 aren't really guaranteed, if you like, because government's ability to put money
are not guaranteed.
is dependent on other factors. So you have 2 billion that's guaranteed.
Yes.
The rest, for this to function, you must have a guaranteed source of income. Only one source, as prescribed in the law, is guaranteed. You are setting yourself up to have a challenge.
No, we are not. That's why we say we are starting it and to perfect it. We are starting it. This 2 billion guaranteed can save lives.
But the 2 billion already is there in the NHIS.
And it's not accessible to these people we're talking about.
So just redefine the NHIS.
And I have explained to you that when you redefine the NHIS, Evans, the whole point I've been trying to make this evening, and I can illustrate that with numerous diseases, is that if you take, and let me use a typical disease. If you take, let's say a cancer. I'm a gynecologist, I'll go to that. If you take cervical cancer, NHIS may support the screening of cervical cancer. NHIS may support the surgery of cervical cancer. When you get to radiotherapy, no 2 people have the same cost of radiotherapy for cervical cancer. We are going to calculate your radiation dose based on the extent of spread of this disease. At the time of surgery, what we found, whether you are having a dose before surgery and after surgery you are continuing, or after surgery you are having only surgery before you go for radiotherapy. So how are you even going to build that in an NHIS system? Our NHIS system is already fraught with a lot of challenges.
Yes.
And it's because it is just diagnosis related. What is going to happen is that you are going to have underfunding or overfunding to the conditions, and you have problem with service providers. You take the kidney that we talked about. Currently, as we spoke, when they decided to support the kidney funding, there are serious challenges because it's not calculated and costed like the way you go with malaria. When you go for malaria, you are taking this. If you ask the kidney patient, there are people who get a dialysis, but the accompanying medications is a big challenge.
And this vehicle
will have a comprehensive approach because what is anticipated is this. I am managing you for chronic kidney disease. You are being managed fine. You don't need dialysis at the moment. I'm giving you medications. You are fine. I'm monitoring your what we call GFR. I'm monitoring your kidney function is declining gradually over the time. I'm your specialist. Then I tell you that, okay, where we've got him to, in about a month, you need to go on dialysis. I assess your income. You cannot pay dialysis. You are NHIS, whatever. It cannot cater for this dialysis. So I'm referring you to this fund to prepare in advance for you. The fund then says, okay, Evans is coming onto the fund. What does Evans need? Evans is 45 years old. Evans needs to be on dialysis for 20 years. If we did a transplant for Evans, it will save us more than putting him on dialysis.
So the fund will actually fund the transplant?
That's what is anticipated. So those that will benefit from transplant and have donors that can match, the fund can go in for transplant instead of dialysis, or can start dialysis for you in the interim and move you on. The fund says that, okay, looking at your HB at which you are starting dialysis, after every dialysis, you need erythropoietin. Madam A doesn't need 15,000 units of erythropoietin. So your cost on dialysis is completely different from Madam A. So if you say you are lumping all that onto NHIS and say anybody on dialysis give 590, the facilities cannot sustain because it's under recovering for some patients, because it's not. That's why we need a dedicated ring-fence fund with a mechanism of rolling the people on. That's why when you read it, we said your specialist.
Yeah.
And a specialist level of care is a specialist. So someone, you are already in the system. Then they anticipate that you are going to a terminal stage. At that stage, this is what you would need.
And answer one quick question for me, because again, part of this is also to educate those who may want to benefit.
Exactly.
Is it only the specialist who can apply for you under the law?
So
because that clarity is what I needed.
You would,
because it says in the law, it is where it's written, it says a patient may through
Yes.
the specialist.
Because it is anticipated that this is specialist level care.
So you see, may, is that when I was reading with my team, so may, does it mean that I can decide to go directly to the fund?
So if you go directly to the fund, we are going to bring out the operational detail, but if you go directly to the fund without being in the system, you won't get funding.
Okay, so
you need to be linked to a specialist.
Okay.
It's a higher level of care that NHIS cannot continue.
Okay.
So at that level, someone recognizes that you need this, or you yourself are at that point that you need it. They've recommended that you need to go through some cardiac therapy. That cardiac therapy involves some form of cardiac surgery. No NHIS is covering that. Okay. Then that cannot be something made by a non-specialist.
Okay, so specialists will have to.
And the other advantage of this, which is so unique, is that it is designed to bring equitable access to specialists.
And you raise a very equitable access. And still on the funding, forgive me, because I know you have a lot. Based on the first, I'll come to you, but this for me is important.
Yes.
Does this act, or bill now, you passed it. We all don't know whether the president has passed, so I'm still.
So let's take it that it's a bill.
It's a bill.
Until it's assented.
Because it's equitable.
Yes.
Does it consider your ability to pay in extending and approving, for example, the specialist care for you? So, for example, it means testing.
No.
One of the ways of, or even if I am a billionaire,
yes,
I can still get my specialist.
No.
That is a very important. When I was doing that, it just occurred to me because
it is important.
I'm a billionaire. I live at Transaco Valley
if you
or
are
Airport
capable
Hills.
of paying. Remember,
but that is not in the law. I didn't see that in the law.
No, that's why I'm saying that you realize that there is a committee that reviews the requests.
But how would the law didn't say that they should look at They should look at your financial capability in assessing
everything in an act. So when we pass an act, we put in that you are going to bring, the minister will bring regulations.
Yes.
Or LIs.
It's in it. The
minister, and the LIs will specify details, what kind of forms to even fill to assess this. All that will be specified in the LI. The target of this is vulnerable people who cannot access care.
That's a very important clarification, except that it is not in the bill
and
you
I'm
passed.
telling you, everything cannot be in the bill.
But this is just a one-liner that you should have just put in there.
It's
such an important
it has
clarifying
been introduced
issue.
In the concept, the memorandum accompanying
because you
this
see,
bill.
it also goes to the sustainability of this
yes.
bill.
So that's the reason why. It's the reason why we said if you put it on NHIS, it's just going to collapse it. Because then everybody, even people who can afford, will just go for it. And diagnosis, someone will require less than that amount, but the same amount will be given. We have to provide tailor-measured services to the people, so that we can improve people's livelihood, improve their longevity, and their ability to produce.
I come back to that question. I'll come to Kwame on this, and I'll come, Alex, you first before Kwame, because I think this is, for me, one of the most important parts that needs clarity. But the law has already been passed.
Yes.
It says who can qualify.
Yes.
It defines it.
Yes.
A person can qualify if a citizen.
Yes.
Insured under the NHIS.
Yes.
And suffers from a chronic disease.
Yes.
End of story.
Yes. So you are qualified.
That's it.
So everybody, whether you are rich, whether you live,
qualified.
Yes.
But when you have limited resources.
But the law doesn't say that.
And I'm saying that you don't expect an act of parliament, a mother law, to be able to specify, then there will be no need for an LI.
But Evans, why should we...
Alex.
Why should we allow this new vehicle be under the shadows of NHIS? Because now we are saying that before you get qualified, you need to be a card-bearing member of NHIS.
Okay, so it is one of the fundamental principles. Why? And I explained that to you. Let me quickly explain that. His Excellency has the healthcare spectrum of the country covered. We are doing a 3-tiered health financing model. The first tier, which will soon be launched, is our free primary healthcare model, independent of NHIS. Any Ghanaian living in Ghana can walk to any primary healthcare facility for free.
Again, regardless of your ability to pay.
for the primary care level, chief's compound, all of those things, we are making it open to everybody. Then you get to a second level. That second level, NHIS becomes a determinant. And we segregate people naturally, because if you decide that you are using a private insurance, you can decide not to use your NHIS. You can decide that you are paying, and that's where our public district, regional hospitals, teaching hospitals, all these other hospitals are for NHIS people, and those who feel they can finance themselves and do not require NHIS. The minimum that is required of you to demonstrate to us that you will need this kind of support is that you should have the NHIS. That's the reason why you are depending on that. Now you are using your NHIS to access care at a regional hospital. You get to a point and they tell you that here, NHIS cannot continue. You are left with only one or two options: to go sell properties, to go fund me, go all of that, raise funds, or you die. That is when a caring president steps in with a fund like this.
Let me hear Alex. Alex, he's made some very important points.
President without source of funding. You know, I have tried as much as possible not to bring in politics.
Yeah, we shouldn't.
But it's not politics.
Yes, but I have said that, you know, we didn't have to push this hard, because when the president was making this promise, he did not say he was going to tap into NHIS. He said he was going to introduce a new system that was going to take care of chronic diseases.
He didn't discuss his funding sources.
You understand?
Either.
And we thought that
But this by the way, you remember when we had this conversation when we did the manifesto tracker? I think Kwame was on.
Yeah.
I asked you source of funding.
Yes.
And you couldn't quite give me an answer at the time.
Because we...
It's okay. Let's get Alex in.
now you are saying you are not going to impose any tax. You have promised Ghanaians you are not going to impose any tax. But you still want to have a legacy. And that legacy, you want to tap into an already established legacy, which is almost suffering and needs some kind of tweaking. So if you have come into the CAP NHIS, I mean, everybody is happy. The providers are happy because now they think that NHIS is going to be well-resourced and their monthly payments are going to come very often. And then you say, I'm taking 20% out of it to go and invest into my legacy. Yeah. In the name of somebody's legacy.
No.
You understand? Yeah. So it's almost as if you did not tell Ghanaians the truth, because this is what you promised us, and we're very expectant, high expectations, and now you get it established, and then people are now afraid NHIS could collapse.
Let's address some of the substantive...
briefly, just for you to answer something we're just discussing. Okay. Application for support. A person is eligible to benefit from the fund under section blah, 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 through a specialist care. The application under this section may be in a form prescribed, right? That's where the minister will specify that. The fund shall, within 14 days after the receipt of an application under this section, A, approve the application and give notice in writing to approval of the applicant, or refuse the application and give notice in writing on the refusal. I just wanted to bring this to say that it's not a wholesale, that the fact that you are just bearing the diagnosis, whatever amount some private hospital says somewhere and submit will be funded.
And so we had issues with the basis
we need to be...
But it says legislation will clarify that.
So we need to be targeted to help. That's why I'm saying that some people will benefit maximally. For some others, even the therapy being given, when an ethical board sits to review, you realize that. That's why referrals are going to come in advance of your therapy.
Okay.
So you must be in the system already. Someone is thinking of you, realize that you need this in anticipation, and the person puts in a request. So by the time you are there, we have a decision on how you are.
I mean, Alex, he talked about something earlier about why this cannot be under the NHIS's wing, which, as you suggested, which is that because it's end stage, and this vehicle proposes a very comprehensive approach to end stage management, you can't put it under NHIS, as he explained. That sounds
you see,
a strong argument.
Over the last 3-4 years, there's been attempts to expand the NHIS. I mean, we've had breast cancer, we've had some childhood cancers, and a few others. So one would have thought that if these chronic conditions are that important, let's just bring them on board NHI And the kind of mechanism that we're going to use in determining who qualifies, who doesn't qualify, and all that can still be done under the covering of NHIS.
So let me just add something briefly to that. So for instance, you added breast cancer.
Yes.
The treatment modalities of breast cancer, not all are still covered. In breast cancer, people can take hormone.
No, but you know it is because NHIS doesn't have enough resources to cover all that.
And it's because when you put all that resource and make it uniform, I'm telling you, you will have challenges because somebody with breast cancer, all that a person needs is breast surgery.
Yes, but you see, the DRGs could apply in what we are experiencing now. And then when we have brought on the chronic diseases, we could have the same system that is going to operate under the MahamaCares.
No, it can never be the same.
Okay.
So that's why Kwame was telling you, even the NHS that has practiced for a very long time, they have to create an additional body to be able to marry it, to be able to, and with that, one of the challenges that he has perhaps not mentioned, I have Ghanaian people flying from London to Ghana for me to operate on them because of prolonged delays in the NHS system. Because in an attempt to cover universally everything, you have a diagnosis that is urgent. But how to even assess specialists becomes a challenge.
Yeah, I mean, isn't it another strong case why you must have a purpose-built vehicle for this?
No, you see, by including these chronic conditions, this would be something new. So obviously, you need people to help you manage it. The kind of systems you're going to put in place under the MahamaCares, if it's not just because you want to have a legacy that bears your name, then let's just put it under NHIS.
And create under NHIS. Okay. Let me ask, Kwame, there's a few big questions that I need you to weigh in on. And I know you said funding was your thing. So let's start with the funding bit. Let's start with the first main one for me. So the only guaranteed source of funding is 20%.
For now.
But I mean, I'm going by the letter of the bill as passed. The rest is not too certain, depending on so many other factors. I mean, that, for me, raises questions, because all great ideas, as governments have done in the past, have always faced that one challenge: sustainable funding.
You see, it's interesting. I like listening to the politicians when they speak about some of these things. And I always enjoy it because I don't have to be restrained by any political mask. The bottom line is this. The MPP is saying 20% is too much and it might constrain the NHIS. The NDC is saying the 20% is worth it. How are both parties arguing? Where is the actual calculations to say this is our disease prevalence rate for hypertension and diabetes, and therefore these are the number of people who get into end-stage renal disease, and therefore these are the fees and charges from Parliament. So if you do the calculation, this is what they would need. You can do that for cancer. Nobody has that data. Nobody. Both politicians talking in the studio, if you put that straight question to them, they don't have the data. They are squibbling. And for me, that is why I wouldn't say 2.14 billion is too much or too little. Because I don't know. And I'll be the first honest person to say I don't know, because the actual data is not available to me.
So how did they come to the 3 billion annually?
I'm going there. Okay. And if you remember, on the 31st of October last year, when we did the manifesto...
Yeah, on health.
I put out the cost of free primary health care for year one, and I said 1.8 billion Ghana cedis. And you remember, you pushed me and said I should go through the calculation, and we went through the calculation on your screen. And I clearly remember when I walked downstairs, my friend Titus walked to me and said, "Kwame, how did you come by this blah, blah?" The bottom line is, you can ask him. They have got professors and accountants, economists together to cost the free primary healthcare. That was they came up with 1.78 billion for this year. So what am I saying? I don't come out with numbers because I just go on a pansy and at CDD we come out with numbers. We also do our numbers. So I have an idea of how much this would cost. I'm not putting it out because we are not done. But what I can say is that the government is not too far off. Up or down, probably down.
Yeah, I mean,
but they are not.
Yeah, I mean, but Kwame, isn't the real question is? I mean, if you have $2 billion plus from NHIS guarantee, what about the remainder of the amount that from other sources that end guarantee?
That's the question I'm answering. They are not too far off with 2.14. That was why I started this conversation by correcting how much is going to them. They are not too far from 2.14 billion. And so the next question then becomes, what percentage of those people in end stage would access the fund? Then you need to ask yourself, and that's a question you've been asking both political functionaries about affordability. The truth of the matter is, when we had the conversation, Evans, on the dialogue, we made it clear that even if you're a multimillionaire in Ghana and you were diagnosed with a chronic disease and you had to go on dialysis for 5 years, you can be a billionaire to bankrupt you.
Yeah. Yeah, we all know people who are very, very rich who become bankrupt because of...
Yes, so the question you're asking doesn't come in. And that is why, for me, I said, I don't want to have the vehicle conversation, because if I want to have the vehicle conversation, I'll become very statistically asinine, and probably I'll be seen as taking one political party.
But Kwame, on that point, though, I mean, shouldn't we ask again? I mean, shouldn't we add a bit of means testing to this?
No. If we did that, if the dialogue agreed that there cannot be any means testing, because if you did that, even millionaires, and you've just agreed because you moderated the dialogue, that even a multimillionaire will get bankrupt. How do you do means testing? I mean, do you want that person who has worked all his life to earn all that money to become a pauper before the state intervenes?
No, but Kwame, there's also something there about, it says equity. So that young woman, and when we do a dialogue, that young girl, a 16-year-old in Cape Coast who died because the parents are so poor, you're saying will also benefit, and the 16-year-old daughter of the billionaire in, what's the name of the most plush area in Accra, Trasacco Valley, all will derive benefits from the same, at the same level, same amount?
Evans, you and I went to school in the UK.
Yeah.
If you are diagnosed with a cancer in the UK, is the first thing that they think of who your father is and how much you earn?
Of course not, but I guess they had a wealthy
country. No. So I'm answering you.
That's not a question.
I'm answering your question directly.
Yeah.
The second thing is, if you lived in Chelsea or in Battersea, and your hospital was Bath and St. Thomas's, would they say because Boris Johnson lives in Downing Street and is going to be there, you would lie next door to the Prime Minister? We saw it in COVID. Boris Johnson was in the same wards with the ordinary person. That is what true equity means.
But it doesn't matter whether you are... I guess the difference is that because of the limited resources that we have here compared to them...
That is why we need to do the calculation properly to make sure the funds are adequate, based on our disease prevalence rate. Not based on what people have. Because if we go by based on what people have, then basically what we are telling ourselves is that, yes, you worked all your life to make all this money. It's your fault that you've become unwell. Let the disease decrease your affordability to the level of the common man before the state takes care of you. That is communism. And I'm not a communist. I believe in the UK, and that was why I gave the 3 systems. I believe in the UK and Scandinavian system. Irrespective of who you are, if you are the worst drug addict on the street and you are the most richest multimillionaire, if you are diagnosed with the same disease, you will join the same queue. And like Prof. Bayer said, if that happens and you're in the queue and you think you can travel, and that is why you see people travel to Eastern Europe, Slovenia, some come to Ghana to do their surgeries.
And Kwame, because of time, and the few additional questions I need to ask you. First of all, you take 20% from NHIS. That leaves a 20% hole in the NHIS funding arrangement now. How do you plug that so that it doesn't affect the NHIS itself?
That is why I said we need to have the modeling conversation. I have a problem with the 20%. In my estimation, based on the calculations we've done, it's a bit on the high side. Like I said, it's close, but it's a bit on the high side. Number two, the argument about add it on to the NHIS. If you add it on to the NHIS, you'd have to have a separate body within the NHIS, like NICE, like I said in the UK. You'd have to employ people to do those determinations. And those determinations sometimes are heartless. Like you had Prof. Bayo say, you would have to make a decision. If I put this person on this medication at this cost, how much more quality of life is it going to give that person compared with if I put 10 people on the same medication at 10% net cost? So these are very technical areas based on expertise where decisions have to be made. And that is why I'm saying that I am not worried about the vehicle, because if the NHIS was giving that mandate, they would have to employ these people, or they would have to create.
Yeah, but Kwame, answer this additional question for me related to that. Now you are going to create a whole new bureaucracy. They will need a whole separate office. They will need to recruit all manner of people. They will need to pay themselves. That is adding, is an additional cost to the $3 billion, I believe, that we could have just simply given to the NHIS, and they would still have to, yes, employ people, but a fraction of the cost that you require to set up a whole different bureaucracy under new law.
That is why I used the word efficiency when I started this conversation. Because if you give it to the NHIS and they are inefficient, or you give it to a new body and they are inefficient, you'd come out with the same outcomes. The issue is about the vehicle's efficiency, not which vehicle you're using. So if you have the vehicle and you have the right number of people making the right expert decisions, I would rather that than giving it to the NHIS and taking on more people and having inefficiency. So for me, that is why I'm not saying the NHIS cannot do it. They could have done it. But the issue is about how efficient that vehicle is. And for me, politicians, and that's why I say I enjoy listening to politicians. And that is why I went to the dialogue. The dialogue had specific requests, which was ring fence, the money, sustainable funding, a system to determine eligibility, and finally, to ensure that it was equitable.
And answer one quick question on that for me, and I'll come to Alex. Is this current funding arrangement under the bill sustainable, as it is currently?
Well, partly.
Okay.
Because we know that whatever Parliament approves for the NHIS, 20% will go to them. So you have a clear income stream. The reason why I said partly is, unless we do the actual calculations to say these are the patients we're expecting based on our disease burden, nobody can make a categorical statement to that. And even though we are doing the calculation in the background, because it's not finalized, I wouldn't make such a determination because that would be foolhardy.
Okay. Let me come to Alex. Alex.
In the NHI formula, we give 10% to Ministry of Health.
Okay. To do what?
I mean, for related activities. So if you're taking another 20% from what has been approved by Parliament. It means that you are doing 30%. We are here talking about 20%, 20%. It just struck me.
So that's 30% less
30% less
than what NHIS will ordinarily have.
So, but that is factual.
Yeah.
But the truth is
But
that 25% has always not been available to the NHI.
But that isn't why the NHIS is struggling.
It's suffering.
Isn't that why it's struggling?
And that is why, if you have an inefficient system, you are trying to better, and you add more to it, you just multiply your inefficiency.
Yeah, but like that fundamental question I asked Kwame, let me ask you too. So what do you do with the hole that this will leave in the NHIS financing?
So my point is that this does not technically leave a hole.
It does it not?
No.
I mean, because they capped it at 15.
If there's any hole,
But you've added 5% to that.
5%.
Yes. And then you have 10% now that he says also goes to the... So that is 30% cumulatively that is going to be deprived.
That if you look at how the NHIS was functioning in the past few years, technically it's about 5%.
No, once you start using technically,
you know
you're in dangerous territory.
No, I'm not. Like 5%.
The reality is 30%.
Evans, you have admitted, or all of us have agreed here, that previously 10 plus 15, 25% was not available.
But again, we all agree that that's why the NHIS was struggling.
Well,
hugely part why it was struggling.
Partly that the NHIS
delayed claims, as we know.
But currently, as we say it was not the only reason why. Look, the NHIS was suffering also because of releases. There were years, a particular year that there was 0%
the government takes
release.
it, but it doesn't
yes.
to them.
So we have a system where releases are going frequently now, and he can attest to that. And everybody's praising the government for that. And I hope that it will be sustainable.
Let me ask you that
as pressure comes up.
Should we review as an increase the premium?
The premium, if you ask me, the premium contribution to the total funding of NHIS is insignificant. It's not up to 2%. So if you want a better funding for NHIS, my proposition to any government will be formalize our economy more, get many more people to pay SNITs, because majority of the funding of NHIS is coming from the NHIL and SNIT contribution. The NHIL is the largest, followed by SNIT contribution. So if more people are paying SNIT, either as private people or whatever means, more money is generated. If you increase NHIS premium now, I will not argue against it, but it will not even increase the total fund of NHIS by
Alex,
more than 5%.
What do you say to that?
But I'll support...
You were the Deputy Health Minister then, so what's your take on this?
Well, if we actually need resources to take care of this chronic disease, it becomes a different argument, and it becomes easier for Ghanaians to take up this new responsibility, because that chunk of expenditure, I mean, is borne by everybody. You understand? But you see, if you look at this whole arrangement, it feeds into the suspicion that there's a grand design to collapse NHIS and get MahamaCares up. That is what every...
MahamaCares is just taking care of the very small
fraction.
Don't forget that they are going to introduce free primary health care.
That is at the basic level.
At the basic level.
Yes.
You understand? So you have that one from a government that promised one-time premium payment. That was not possible. That was infeasible. The same government. And so if you have that one, and then you are taking off this chunk from NHI to feed that tertiary level care, it means that you are making NHIS operations quite insignificant.
Evans,
in the scheme of things.
The clarity Ghanaians must know from this discussion is that this fund is not a competitor to the NHI.
Yeah, but I think I don't have a good answer yet to how you plug the 30% hole that this, in addition to all the other funding distribution that will come, that this will leave.
You see, I don't think your assumption is right. Your assumption is that NHIS was getting 100% and 30% is going. And
I think that what we all know that.
And I say so don't say plug a 30% hole, because ab initio NHIS.
So you're saying 5%.
So
that was the whole.
Yeah, but remember that we all agree that that 5% now plus everything else that's going to happen.
Yes.
Is why the NHIS was already struggling.
Well, the tariffs.
Exactly. So remember that the NHIS itself is a system or a structure that isn't perfect, isn't efficient.
Exactly.
So for a lot of reasons. Part of it is funding.
Yes.
Other government not paying on time.
Yeah.
or
not paying the realistic tariffs.
and it was capped and all that, right?
Yes.
But then you are now taking a chunk out of it. Kwame says 20% is too much.
Making it more vulnerable.
Definitely you are adding on to the problems that already exist.
So what we have
how
done,
do you fix
what
that?
we have done to the NHIS so far is that we realize that what the engine or the oil needed to oil the engine of NHIS is frequent releases. That is the basic thing for NHIS to survive. And that is happening consistently. Because claims are being paid month on month, facilities are able to run. Now we can go to the next level. There are two problems the NHIS needs to solve. First one is the problem of co-payment, which is illegal payment. Now, if people are getting their money frequently, can we address that? The second one is realistic tariffs. Because if realistic tariff is not solved, and there are delays in payment, then co-payment, which is illegal, becomes difficult to eliminate.
I need to ask two quick questions before I wrap up briefly, because this is important for people.
Yeah.
So when can I start applying for this fund?
Okay, so a few things need to happen. It's the reason why we're so much in the hurry. The first is that the president must assent to the bill and becomes law.
So if he assents it tomorrow,
if he assents it tomorrow,
when can I go and apply?
The next steps is that we need to set up a secretariat, open bank accounts for funds to be transferred, and then the forms for application must be produced. So this will take us a few more days. And hopefully, once that is done, then you can apply. So I can't sit here and give you that once it's assented, within a week, 2 weeks, or 3 weeks, you can apply. But you have hope that once it's assented, some funding is being made available to you, and that this is a disease that you are living lifelong with.
Okay.
But that there is some hope coming. Even if you are struggling to sustain yourself now, some hope will come in.
Once you get under the MahamaCares arrangement, you are taken care of till you die?
We know, because it's a chronic condition.
Okay.
Unless your condition improves so that you don't need care again.
But another question.
But this is a condition you live with.
Another question I need to ask you, and this is a political one, but it's an important one.
Yes.
You've written into the preamble the Ghana Medical Trust Fund, which is the official name of the act.
Yes.
And then you say also known as MahamaCares.
Yes.
Isn't that politically incorrect? Because then, if MPP wins tomorrow, why would they continue
that preamble?
A law that says MahamaCares?
Somebody is bringing a bill to Parliament. The person has.
But was the MahamaCares necessary? You remember what happened to Obamacare in the US?
It was.
They have always referred to Obamacare.
It was
but when the Republicans took over.
So fortunately, unless somebody who doesn't think of the well-being of the Ghanaian, the actual act, when approved, the bill which becomes act, we were mindful to make it neutral. This is somebody.
But it's in the preamble.
No, but that preamble is not going to be part of the act. The preamble is introducing the bill to us. When it came, our colleagues on the committee said we should expand it from it. The lawyers and the technical people said, look, someone introduces something to you, a memo he has brought to you, you can't amend that memo. You can amend the act. Parliament has a right to amend the bill and reshape in any form we want, and we've done that.
Alex, that
was a fact.
That is a condition that you accept.
Well, we didn't accept that explanation, but we felt, this was part of the grand scheme of propaganda. Just making sure that you create a legacy for Mahama. No. Because during the campaign, one of the things that he suffered was the fact that of all the presidents that the Fourth Republic had witnessed, he's the one who didn't have a legacy.
But if somebody has
now, let's create a legacy for him. And if we're creating a legacy for yourself,
such a novelty,
you don't call it a novelty when you're going to depend on an existing fact.
It doesn't deserve a mention.
A novelty?
Even in the memo of the bill.
You call that a novelty?
In the memo of the bill?
It's fascinating conversation because it has to do with health. And I know we haven't explored everything. We need to return. Once it's passed and implementation starts, Kwame, I'm going to invite you back here so we can unpack this a bit more. Enjoy the rest of your evening.